We're here at the International Conference on AIDS in Vienna. We're here with Joel Gallant, and we're kind of do a wrap-up of some of the treatments that were talked about here at the conference, and Joel is always so gracious to give us that opportunity to do that, and we appreciate that again.
Thanks, Rick. It's good to be here again.
All right, thank you.
I think, you know, these international conferences often have big themes that go way beyond things like antiretroviral therapy, which is what you and I usually talk about. I'll just touch on that, but then we'll move on.
Right.
I think the clear themes here were the issue of human rights, and we're here in Austria, right on the edge of Eastern Europe, near the former Soviet republics, where there's a lot of issues with criminalization of injection drug use, criminalization of behaviors that could transmit HIV. And so there's been a lot of emphasis on that here. There's been a lot of emphasis on prevention, and specifically on treatment as prevention, or antiretrovirals given in various forms, including the big news on the vaginal microbicide. So that's been certainly big. But of course, you don't invite me here to talk about those things.
Yeah.
I'm here to...
But you saw it too.
Yeah, oh, I saw it too, and we can touch on that. I mean, clearly the news up till now on microbicides has been pretty negative, but this is the first time we've actually used an antiretroviral as a microbicide, and for the first time we saw positive news in that this clearly had a protective effect for women. Interestingly, it also had anti-herpes effect, even though tenofovir itself, when given orally, has no anti-herpes activity. Apparently, when you get a high enough concentration using a gel like this, topically, you actually do get benefit in terms of herpes.
And you're so into the resistance issues. Do you think about that when they were presenting any resistance? I mean, I know there's been some discussion about that.
Yeah, of course it's a concern. I think it's even more of a concern when we talk about oral, like PrEP, for example, which is, we should be hearing results about PrEP, pre-exposure prophylaxis, at upcoming conferences. It's definitely a concern, but I think we have to do the studies to find out. You know, I would just point out that there was an enormous enthusiasm for this study, and for good reason. It's an important proof of principle. It shows that there's biological plausibility to the idea of using a microbicide, and for the first time it puts protection and prevention in the hands of women, who often kind of get left out of that equation. I would point out, though, that it was 50% effective in the most adherent women, and so it's not like the kind of effectiveness we tend to talk about when we talk about treatment, which is 90–95%. And this may not be the actual product that they go forward with. There may be improvements that have to be made. I also think that I think the expectation is that PrEP, taking pills orally, will probably have greater efficacy, but it's still an enormous advance.
And it's a part of the arsenal.
Yeah, exactly.
Hopefully it will be used that way.
Yeah, we definitely need better forms of biomedical prevention than we've had, and so this is a big step forward.
Great.
So moving on to antiretroviral therapy, I think if there were any big themes, one would be early treatment. This continues to come up conference after conference. There's more and more evidence showing that we should be treating earlier. There was a really interesting sort of a panel discussion about when to start therapy. And as you know, the ISUSA guidelines were released during this conference and are now very similar to the DHHS guidelines, which say treat below 500, consider treating above 500. There's a lot of data supporting this, showing that your CD4 nadir, the lowest CD4 count you had before treatment, is predictive of things like bone disease and cognitive decline and things like that, and that you may not always recover from the things that happen to you as you wait to start treatment. So starting late is a bad idea. There was the Cascade study, which is yet another large cohort study presented by Joe Aron, looking at the question of when to start. The statistics are very complicated in most of these studies, and often way above the heads of me and other people in the audience. But the bottom line in his study was that they clearly found that there was a benefit to starting in the 350 to 500 range, consistent with many other cohorts. Unlike the NA Accord cohort, they did not find a benefit starting above 500, but they pointed out that they weren't looking at non-AIDS related morbidity. In other words, if heart disease and cognitive decline and bone disease and all those things are in fact related to when you start therapy, they were not looking at those things. So you have to, I think, take that with caution. But it certainly supports the current guidelines. It says we should be starting below 500. There were a number of antiretroviral trials presented and lots of acronyms that I have had to take notes to keep all these study names in my head. One is the ECHO and THRIVE studies presented by Cal Cohen, and these are two almost identical studies comparing the new NNRTI TMC 278 or rilpivirine and comparing that against efavirenz. So everybody got 2 nucleosides plus either rilpivirine or efavirenz. And overall, the rilpivirine was non-inferior to efavirenz, but with a caveat. It was better tolerated, but there was more virologic failure and more resistance with rilpivirine. So the two kind of canceled each other out, if you will. Fewer people stopped rilpivirine because of side effects, but more people failed with it. And when they failed, they were more likely to have nucleoside mutations or specifically a rilpivirine mutation that sort of knocks out etravirine or Entellins. So, you know, this is one of the concerns is that right now we have a sequence of 2 non-nukes that you can use. You can start with efavirenz and then you can go to etravirine. If you're using rilpivirine and you fail, you are less likely to have that second step. So it's kind of it was kind of mixed news. Clearly better tolerated from a CNS side effect standpoint. And it looks like it could be an attractive drug for people who, for example, are not tolerating efavirenz because of mood changes or cognitive changes, could perhaps switch to that. But it may not be quite as effective as what we're using now.
But if the resistance profile demonstrates that it's the better choice, then...
Well, it would be unlikely in a naive patient that you would ever have a different...
Yeah.
Unless, of course, you were infected with a resistant virus. If you were infected with K103N or something like that, it could be a good choice, though they don't have data for that kind of use of the drug. We heard about the Shionogi GSK integrase inhibitor, the 572 is its sort of nickname until it gets a better name. And we heard 2 different studies. One was the Spring 1 study in naive patients where they, it's a phase 2B study. They compared it against efavirenz, and it looks quite good. I was particularly interested, though, in the study where they looked at patients who had already developed resistance to raltegravir, the existing integrase inhibitor, to see whether they would respond to 572. And what they found was interesting. If you had... for the most part, if you had sort of typical mutations for raltegravir, you did well on 572, with one exception. If you had the 148 integrase mutation plus other integrase mutations, you tended to do poorly on this drug. And no one just had a 148 by itself, so they couldn't really test that. So if you had a 155, which is often the first mutation that occurs, you did well. But I think there's a real note of caution here that this is telling us that there is a second-generation agent coming, but that you could really lose it if you stay on a failing raltegravir regimen. We've heard, you know, I'm sure I've said this in previous interviews where we talked this way about efavirenz. You know, if you fail efavirenz, you should get off of it quick so you can save etravirine. Now we have etravirine. That turned out to be true, and now we're saying the same thing about raltegravir. If you're failing raltegravir, get an integrase genotype and get off the drug.
How would you stage the resistance testing in that?
Well, I think anytime you're failing, anytime you're failing a raltegravir-based regimen, you need a regular genotype or phenotype, but you also need an integrase genotype. And I would specify genotype, not phenotype, because the genotype is going to tell you whether you're susceptible to 572. The phenotype, all it's going to do is tell you whether you're resistant to raltegravir, which is not very helpful information. So I think that's an important lesson as we wait for this drug.
But you would do that within weeks?
Well, I would do it as soon as you have a high enough viral load to be able to measure it. Yeah. There was a study on long-acting or extended-release nevirapine. This is a new product that's designed to be taken once a day. Interesting because nevirapine, we've always known it has a long half-life and could probably be given once a day anyway. But they've developed a new product that they hope to get approved for once daily dosing. And they compared it against standard nevirapine. It looked quite good, but interestingly, this wasn't mentioned in the presentation, but then at the end when somebody asked a question about some of the serious nevirapine toxicities that we associate with that drug, it turned out that 5 people developed Stevens-Johnson syndrome, which can be a fatal skin reaction, and that 14 had been discontinued due to hepatitis and 21 due to rash. So,
and what was the number on that trial? Do you know?
It was called the.
I mean, as far as the number of people.
I'm sorry. Yeah, it was several hundred. I don't remember the exact number, but it was a large trial. So I think this new product looks like it's certainly a good alternative to what we've been using in terms of nevirapine. But I think it's still nevirapine is always going to be a drug that has a hurdle in that first few months of therapy where side effects can be quite serious. Once you get beyond that, it's a really well-tolerated, effective drug. But I think the reason why it's not used much in the States has been the concerns about the early toxicity, which is more severe than with other drugs. There was a Spartan trial, which was looking at unboosted atazanavir or Reataz combined with raltegravir or Icentris as a 2-drug combination for naive patients. And although it kind of on the surface, the graphs and curves all look good, it turned out both companies involved stopped the study because they said it's twice daily dosing, you get more bilirubin elevation, more jaundice, and there was resistance to raltegravir that occurred at an unacceptable rate. So I think, and not to mention the fact that this would be a very expensive combination to use. So
and that was probably the big purpose, to say this would be hopefully a dollar saving.
No, so I think there is a lot of interest in so-called nuke sparing options where you usually it's a boosted PI plus something else that isn't a nuke. So, for example, a boosted PI plus raltegravir, and that brings me to the PROGRESS study, which was the lopinavir, ritonavir, Kaletra plus raltegravir study compared to Kaletra plus tenofovir FTC. Looked very good, non-inferior. That's more, I think, along the lines of the kind of nuke-sparing option that we could all say is a reasonable idea, a safe idea. I think using an unboosted PI like atazanavir, where all you need is 1 mutation to get resistance, plus raltegravir, where all you need is 1 mutation to get resistance, put it in a twice-a-day combination. It's a little more shaky, I think, than a boosted PI plus raltegravir. Right. Though, it raises the question of when you have a boosted PI in a person who's naive to PIs, we know that most boosted PIs do pretty well on their own, even with monotherapy. Not quite as good, but they're pretty effective. So when you add that second drug, you kind of got to wonder, well, what is the second drug contributing?
Right.
Would they have done just as well without it? And there's studies now looking at things like a boosted PI plus generic 3TC. This idea, as cost becomes a more important factor, even in the U.S., where we've tended to ignore it in the past, I think we're going to see more and more of these things, these approaches looking at ways to reduce the cost of regimens without sacrificing potency.
And that's a good question. How does a doctor move a patient off of a large combo, dropping something they particularly wouldn't want to use? Probably not for cost, but just for pill burden or many other reasons, maybe side effects, and without risking the regimen. Is that something that doesn't probably go down without some risk?
Yeah, there's always a risk whenever you make a change. On the other hand, I think if you have a good treatment history, and you know what the patient's been on before, you know what resistance pattern they have, you know, for example, if they're on a boosted PI, and you know they had no PI resistance.
So you're taking out some of the guesswork.
You take out the guesswork. Now the problem is, when patients show up, they move from state to state to state. They come to me. They've had 5 different doctors, and they don't have any records, and the doctors don't get the record. I think then it's really guesswork, and that's why I encourage patients to
and you
keep
need that
records.
Long history, because a lot of people move from a good regimen to another good regimen, mainly because they just wanted to change drugs.
Right.
So there's no resistance testing in there that's going to be useful.
Exactly.